So it's really a thrill to be at Geisinger Health System because it is a fully integrated, vertically and horizontally integrated healthcare system, and it has its own health plan. Yeah. And so the approaches to change at Geisinger were in some sense more holistic, as opposed to some of the typical barriers, meaning the way you're reimbursed, a fee-for-service as compared to a capitated model. Geisinger's approach was very much towards value in general, and doing the right thing for patients. The approach that Geisinger used I would call process reliability, trying to make sure that patients got all the things they should get all the time for any given clinical condition, and that was branded as proven care. And they were set up as clinical bundles, so maybe these 8 things for diabetes, these 5 things for another chronic obstructive pulmonary disease, another condition, and the like. And they had a series of these proven care protocols that led to process reliability, which helped patients get better outcomes and lower total medical expense. And there were fewer barriers at Geisinger to innovation because, as a part of the way almost everybody was paid, they had a portion of their salary that was tied to innovating. So whereas in another place you might go to somebody who's really busy and say, would you help to innovate and change? They would say, I'm really busy. At Geisinger they would say, wow, this is great, let's do something because I need that for my compensation schema. I think that was a very important ingredient. What it did is it created an activated organization where people were motivated and interested in change, and they saw that as a positive as opposed to a disruption to the status quo. So it was really fun to be there. I'd say the other thing that we worked on were changes to the system. We didn't ask people to change as much. We tried to make it easier for people to do the right thing, to develop tools that made work easier, and by virtue of making work easier, it improved outcomes and more often than not avoided costs, like avoided a hospitalization. We also challenged groups like the paramedics who were incredibly helpful in reducing readmissions for patients with heart failure because they could go to a patient's home, they could administer a diuretic IV, and they prevented an emergency room visit. Lo and behold, the paramedicine folks, who would have thought that really not the top of the most highly trained professional, but the paramedics would have such a profound impact. So we tried to activate the whole organization, and it really was fun and energizing, and it's part of the reason that Geisinger has been so successful. Leading Atrius Health has been a privilege, and it has also been a journey. We are in many ways like Geisinger because we get about 75% of our revenue through capitation, so we behave like an insurance company. And we, like Geisinger, are on Epic as our electronic medical record, and it has all the positives of being on Epic and some of the detractions of being on Epic, some of its complexity. And what we've really been working on is re-engineering the workflow. So here the opportunity is, as I mentioned, Geisinger make the work easier. It's make the work easier for our clinicians and other providers. And that has been working to redesign some of the systems inside Epic, and then to work with local partners like IBM Watson to develop a new way of displaying information or analyzing information, and to take advantage of the richness of the environment that we're in. So to me, it's been about developing that same kind of process reliability. And if you look at our scores, for example, we're amongst the top in the country in our performance in the Pioneer ACO. Likewise, we do well with other incentive programs tied to quality. So to me, it's been about improving the system, redesigning the workflow, and enabling people to work at the top of their license. So everybody, like the paramedicine folks who could have an impact, everybody can have a positive impact on care and outcomes. The digitization of healthcare is an extraordinary advance. It has been a necessary but not sufficient step in the evolution to dramatically improving care and outcomes to be able to apply data analytics to large amounts of information. We're still not there. Part of the reason that there is so much work being done now with natural language processing is to be able to read non-digitized information and to be able to integrate that with digitized information and perhaps speech and other text-based content. So it's a necessary but not sufficient step, and I'd say we're at the beginning of that journey of being able to use advanced analytics and simulation tools to be able to intervene in what is described by as Gartner as an actionable analytic. The magic of being able to identify populations, to be able to then not describe almost by definition that this is the condition that they have and that these are the things you should do when this happens becomes really, really critical. So getting to the point of using digitized information for the sake of analyzing, creating populations, identifying people with specific needs, and then doing something that's of value to them and to the healthcare system, I think is the journey. And it's a journey. We're not mature in any sense of the word. So medical education right now, I believe, is in transition, not only because of the digitization of our world, but because the nature of the way we're providing care will change. And it is changing. So we describe several different layers of data analytic expertise. So those people that can just extract the data to identify a population and present it at a very basic level. Those people that can analyze it and get a little bit more analytic, more advanced. And then those people that can take all that information and build simulations and models and predictions. So they're very, very different. I think we'll need people who can use all those skills and who understand and crosswalk the clinical part of medicine to those analytical experts. Because sometimes mathematicians are not physicians or physical therapists or occupational therapists, so we need that bridge. And I think that the way work is being performed is going to change. I'll use pharmacists as an example, where historically pharmacists might dispense meds or maybe have an expertise and work in an ICU. You're going to see more of what's called clinical disease therapy management, CDTM, clinical disease therapy management, where clinical pharmacists under delegated protocols are going to manage entire conditions like diabetes and hypertension and chronic obstructive lung disease, and perhaps more complex conditions like pain, where there's this narcotic epidemic, and now we may be able to turn to alternatives to narcotics. And the clinical pharmacists are experts in knowing how to use those drugs. And they're expert in one other thing, which we tend not to talk about enough, which is medication adherence. So more often than not, part of the reason people don't get better is they don't take their meds properly, or they don't take them at all. There's an incidence of primary non-adherence of about 30%. So I write a script for you, and about a third of the time you never fill it. So getting experts in this space, clinical pharmacists involved, will be extraordinarily helpful. And just to use that as a paradigm for analytics, we now have the ability to get from express scripts how often people are refilling their meds. So if you're not refilling your meds as often as you should, you're probably not taking them as often as you should. And it gives us the opportunity to apply an intervention, whether it's through education or behavioral modification, to get people to take their meds so that their outcomes improve. So there's a world of need as it relates to expertise in new areas, driven in part by better understanding of the data, but also a change in the way we're going to provide care.